The most important changes in these new guidelines are probably related to our introduction as a class 1 recommendation to measure biomarkers before surgery as a risk prediction marker, and also to repeat the biomarkers that the cardiac troponins after 24 and 48 hours after surgery in order to detect what we call perioperative myocardial infarctions. And that means a big change compared to previous practice, and also but it has been shown to be very important because elevated biomarkers before surgery, they tell us that these patients are at increased risk for complications, and it's therefore utmost important that we do what we can to reduce the risk before surgery, and also that we monitor these patients extra during surgery and after surgery. And if troponins get elevated after surgery in accordance with the definition of a perimyocardial infarction, it's very important that we also try to find out what is the cause, because this is a heterogeneous group of patients. In some patients it's due to myocardial ischemia, in other patients it's due to hypotension or arrhythmias. So it's very important that we try to find out what is the cause and treat the cause in order to reduce the risk of serious complications as death. The incidence varies a lot depending on what kind of surgery. It's of course much higher if it's high risk surgery compared to intermediate or low risk surgery. So I think it's very difficult to come up with a figure here. But what we know is that more than 4 million people die postoperatively every year from surgery. So, and that makes postoperative deaths the third most important cause of death worldwide. So we really need to improve our care of these patients in order to reduce the number of these postoperative deaths. So I think we haven't been good enough, but now we have had some new tools, particularly with these biomarkers, in order to identify those patients with highest risk. And then the next step is that to use it, implement this in practice, and also then to try to reduce the risk in these patients as much as we can. As we have in these new guidelines, we have made many flowcharts and figures on how to manage these patients. But with respect to initial assessment of all patients, we recommend to take an accurate history and do a full clinical examination, including standard blood tests as hemoglobin and creatinine. And then in patients with a elevated risk, as patients with previously known cardiovascular disease, and in all patients above the age of 65, because we know that the age is an important risk factor for postoperative complications. In all those patients, we recommend to measure troponins or BNP, or both of them, in addition to do an ECG. So that is the kind of first risk stratification. And if we then detect patients with elevated troponin and BNPs, we have to try to find out what kind of disease is it behind this, and to treat this disease, if it's heart failure or an ACS or what it is, to treat this optimally before the patients undergo surgery. And also, as I said already, we have a very strong focus on biomarkers in this new guideline. So it's not just before surgery, it's also in the postoperative phase. We have to monitor with troponins in addition to the more usual things as blood pressure and pulse and ECG. That's a very good question. There have been performed quite a few studies in order to try to find what we call risk reduction strategies. For instance, studies with initiation of specific drugs 1 day or two before surgery, for instance, beta blockers, aspirin, clonidine. That's just a few, but none of these have been shown to be particularly beneficial. So we cannot recommend starting any specific drug therapy in order to reduce the risk, but what we know that the risk is smaller if the patient is in a stable phase. So if you have heart failure or hypertension, for instance, or ACS, you should stabilize the situation and treat the patient according to the guidelines for heart failure, hypertension, ACS, to be sure that the patient is optimally treated before surgery, and that then the risk for complications will be lower.
Mm-hmm.
And what we also have found out recently is that if the patient is smoking, it's very useful to stop smoking. Stopping smoking will reduce the risk of complications significantly, also the risk of death. But you need to stop smoking at least 4 weeks before surgery, so you have to plan this, or you have to postpone. If the patient is smoking when he presents for surgery, you should talk to him about quitting smoking, and then postpone the surgery for some weeks,
Okay.
because that will reduce his risk of complications. So it's really important.